Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about diseases of the pleura, particularly pleural malignancy, and this is going to be the last topic under the discussion of thoracic imaging. Now, metastatic disease is the most common cause of pleural malignancy. Lung and breast cancer, gastrointestinal and genitourinary adenocarcinoma, and invasive thymoma can metastasize to the pleura. So this image shows us a case of chest wall metastasis, and it's an axial CT image which shows a heterogeneously enhancing mass invading the chest wall and adjacent pleural surface of the lung. This was a case of breast cancer metastasis involving the chest wall and pleura. Now to multiple myeloma or plasmacytoma, which involves multiple bony lesions. You could have osseous metastasis that may have soft tissue components, and some of these soft tissue components, being extrapleural, may secondarily invade the pleura. So these images show multiple variable sized lytic areas. So if you look here in this region, you can see this lytic region in this bone. We can see some here, we can see another one here, and these appear to even have soft tissue components to them. There's another one here and a very big one here. Some of them appear to also push and invade or involve the pleura on the right side, like here, and even this one here as well. There's even a little bit of pleural involvement in this one here and here. Now, a prime diagnostic consideration is multiple myeloma, but also another possibility can be bone metastasis. Mesothelioma is a highly aggressive neoplasm arising from the pleura. Most cases are due to prior asbestos exposure with a latency of more than 20 years. The epithelial subtype is more common and it has a slightly better prognosis. The sarcomatoid and the mixed subtypes of mesothelioma are more aggressive. CT of mesothelioma typically shows nodular concentric pleural thickening, often with an associated pleural effusion. The role of surgery is evolving with the goal to resect all visible tumor. Trimodality therapy involving surgery, intraoperative heated chemotherapy, and radiation has been shown to provide benefit for a subset of patients. So this image is a contrast enhanced CT of the thorax, and it shows extensive nodular pleural thickening of the left hemithorax, almost circumferential. There are a few areas that are spared, but it's almost circumferential nodular thickening of the pleura. This was a case of mesothelioma. Now we'll talk about fibrous tumor of the pleura, which is also known as solitary fibrous tumor. It's a focal pleural mass that's not related to asbestos and it's not related to mesothelioma, and definitely not mesothelial in origin. Approximately 20 to 30% of fibrous tumors of the pleura are malignant, and so all are excised. The malignant potential is determined histologically by the number of mitoses seen within the cells. Now, fibrous tumor of the pleura may be associated with hypoglycemia or hypertrophic pulmonary osteoarthropathy, although these associated conditions are uncommon, just about 5% of cases. Fibrous tumor of the pleura may be pedunculated, and when you have a pleural-based mass that changes position, it's suggestive of a fibrous tumor of the pleura. It also tends to have low FDG uptake on PET scans. So this image is a case of fibrous tumor of the pleura. It's a CT scan axial, and it shows a circumscribed mass with a broad attachment to the pleura, confirming that it's pleural based. This was a fibrous tumor of the pleura. Now, just as a bonus, we'll talk about pleural effusions briefly. A transudative effusion is caused by systemic or local imbalances in hydrostatic and oncotic pressure. So when you have high hydrostatic pressure or low oncotic pressure, you end up having transudative effusion as fluid leaks out of the capillaries. Common causes include systemic low protein states, heart failure, and nephrotic syndrome. An exudative effusion is distinguished from a transudate by thoracentesis. There are no reliable imaging features to distinguish between transudative and exudative effusions. And exudative effusions implies there is some pleural disease that is causing increased permeability of the pleural capillaries. It has nothing to do with the pressures within it. It's just the permeability of the capillaries that is affected by some disease process. And some of these diseases include pneumonia with a pneumonic effusion, empyema, or tuberculous pleuritis. You may have some pleural disease like mesothelioma or pleural mets. Rheumatoid arthritis or some other collagen vascular diseases can also be implicated. Then chylothorax is a pleural effusion consisting of intestinal lymph, most commonly caused by iatrogenic injury and less commonly neoplastic obstruction of the thoracic duct. Chylothorax is also associated with lymphangioma. We saw this in the discussion where we talked about diffuse cystic lung diseases. The thoracic duct originates at the cisterna chyli in the upper abdomen, and it drains into the left brachiocephalic or subclavian vein. Malignant pleural effusions are also a kind of effusion. They are mostly the exudative kind because they are from some disease process affecting the pleura. Unexplained recurrent pleural effusions or unexplained large pleural effusions should raise suspicion for underlying malignancy, regardless of whether there is associated visualized pleural nodularity or not. Some other features of malignant effusions include nodular pleural thickening and thickening of the mediastinal pleura. And of course, if there's a history of primary malignancy and then you end up seeing some pleural nodularity with an effusion, should be guessing that this could be a malignant pleural effusion. So this case is a case of breast cancer, and we have some mets to the pleura. You can see these areas of pleural thickening and associated effusion. Of course, there are other things going on in this chest, but I just wanted to point out the malignant effusion going on as well. Thank you very much for your attention throughout the discussion of thoracic imaging. It's been quite a ride. Next, we are jumping to gastrointestinal imaging. If you found value from this discussion, give it a like, give it a thumbs up, share to someone you might think would need this, leave a comment, and subscribe as usual if you have not subscribed yet. I will see you in the next one.